Okay, yes. Everyone, we're getting ready to start the program. If you'd like to get your meal and find a seat, please. And sponsors, please enjoy a meal and have a seat as well and enjoy the program. If everyone wants to get the meal and we'll start the program. We will be starting the program within about 1 minute. If everyone would like to help yourself to your meal and find a seat. No, wherever. No, wherever. Yes. And sponsors, please join us wherever you would like to sit. We at 6 o'clock. Okay. Sure, you may. Yes. Thank you. Six. Okay. Hello, everyone, and thank you for joining us for tonight's program. My name is Kathleen Davis, and I'm the Executive Director for the National Kidney Foundation of Eastern Missouri, Metro East, and Arkansas. Welcome to our professional education program, Nephrology Care Challenges and Clinical Innovations for 2023, presented by fellows of the University of Missouri School of Medicine, St. Louis University School of Medicine, and Washington University School of Medicine. Tonight's Renal Roundtable is in association with Dr. Khanna, Dr. Malhotra, Dr. Misra of the University of Missouri School of Medicine, Dr. Kaliskan, Dr. Lentine, Dr. Madakuri, Dr. Philip Neri, and Dr. Vo of St. Louis University School of Medicine, and Dr. Alhamad, Dr. Chang, and Dr. Delos Santos of Washington University School of Medicine. Thank you for your collaboration throughout the planning and implementation of this important program for the renal community. We have a great program in store for you this evening and appreciate your time spent with us, as your expertise is valuable to the success of tonight's engaging discussion. I want to share an upcoming event reminder for our local NKF market, and I encourage you to participate in our upcoming St. Louis Kidney Walk on Sunday, March 26th at 11 a.m. Registration is open on our website. I also want to mention a few housekeeping items as well. If you have any questions throughout the program, please feel free to type them in the Q&A box that you will find at the bottom of your screen. And to clarify who the question is directed to based on the topic covered by the fellows. Our moderators this evening, Dr. Alhamad, Dr. Lentine, and Dr. Malhotra, will direct them to the presenters to answer during our Q&A portion. You are also welcome to utilize the Zoom chat box. I want to mention a few housekeeping items as well. The restrooms, they're located just to your left here. And following tonight's presentation, we'll also have a Q&A portion. For those here in person, feel free to raise your hand to ask questions at this time. For those virtually present, if you have any questions throughout the program, please feel free to type them in the Q&A box that you will find at the bottom of your screen, or always feel free to use your Zoom chat box. We will be sure to address any question in the Q&A portion of the evening. I want to now thank our sponsors, and our gold sponsor is Alexion for supporting this evening's program. Our silver sponsors that are here tonight Casey, Horizon Therapeutics, Otsuka, Amgen, Calliditas Therapeutics. Tracy can correct me later. Sanofi, Fresenius Medical Care Renal Pharmaceuticals, and AstraZeneca for allowing us to gather this evening. Thank you very much. I will now introduce, I would like to now introduce Dr. Kunal Malhotra. He is the Associate Professor of Clinical Medicine at University of Missouri Hospitals and Clinics. He is also the Director of the Chronic Dialysis Unit of DCI in Fulton, Missouri. Thank you, Dr. Malhotra.
Hello, everyone. Thank you, Kathleen. Thank you, NKF. Thank you to my colleagues at WashU and SLU. And thank you to all the sponsors for coming here and supporting our fellows. And thank you to the fellows for taking this opportunity to present. This event wouldn't be here if there were no fellows. So 3 cheers for fellows. Here, I would also like to introduce our division of nephrology. We have nephrologists at VA at University of Missouri, and we have our office support staff and our nurse practitioners here. And because of everybody's effort, we rock on every day. Oh, I'm going backwards. These are our fellows. You'll meet 2 of them today, but also Dr. Lee and other first-year fellows who are here in spirit and cheering on our 2 fellows. The 2 fellows we have today are Dr. Manoj Datta. He came to University of Missouri from Saudi Arabia, where he had done nephrology and was practicing nephrology for a number of years. Before that, he did his medical school from Dhaka, Bangladesh. He has been an asset to our program ever since he landed because he brings unique experiences and perspective to our program. He's very humble, he's very grounded, and his patients love him for that. He has a very great knack for curiosity. He looks for learning opportunity in even the simplest of cases. And I learned from him that you can have a learning opportunity anywhere you look. So thank you for that. He demonstrates great work ethic and regularly volunteers to help his peers out. I think everybody in our division and his patients love him. So he'll be presenting the second half of the presentation. The first half will be presented by Dr. Zaid Al-Dahabrah, who received his medical residency education in Jordan. He came after completing internal medicine residency at Jordan Hospital. And let me tell you, he just fit right in. People usually say that when you start fellowship or residency in US, when you come first time, there's a steep learning curve. We never felt it. He knew the EMR, he knew his way around the hospital, and he was always very calm, and he still has a very calm demeanor. I've never seen him flustered, anxious, angry. He calls himself a soccer fan. I don't know how, because those are not the qualities of a soccer fan. His medical knowledge is vast, and his steady, calm demeanor just tells us, I got it, you relax. Even in any busy inpatient service, on any day, he's on top of it, always ready on rounds, and the attendings don't have to worry about anything. So I welcome our 2 fellows on the stage, and while they are coming, I would also like to mention for all the fellows, we host annual dialysis conference, and it's back in person in Kansas City in March of this year. And we are glad to announce that we have grants for fellow. All the fellows who want to attend annual dialysis conference, their registration will be waived off. We also have grants. So if they submit abstract or oral presentation, we have a fellows forum. We have travel grants for them to come and attend annual dialysis conference. So please, all the fellows and all the attendings, please come to the dialysis conference later early next year. And without further ado, please come in.
Thank you, Dr. Malhotra, for this nice presentation and introduction. My name is Zaid Al-Dahabrah. I'm one of the MU Nephrology Fellows. So happy to be here. Thank you all for joining. Special thanks to the NKF for this nice opportunity. And people on Zoom, also thank you for joining. Today, I'm going to be talking about the challenges in hemodialysis in patients with liver cirrhosis. And my colleague, Manoj Datta, will also talk about an updated review of AKI and hepatorenal syndrome. As we all know, hemodialysis has been going through a revolution recently with recent changes in the machine, in the axis, and all of that. And writing a good and specific hemodialysis prescription to each kind of patients really make a big change. And there's nothing that's called one prescription for all of hemodialysis patients. I'll go ahead and review a case that we faced in MU and show you the challenges that we faced and how we went over them. So our case today is a 53-year-old female patient. She has a known medical history of decompensated liver cirrhosis due to NASH, history of frequent paracentesis, and history of variceal bleeding with multiple endoscopic band ligation. She's also type 2 diabetic, hypothyroidism, COPD, B-cell lymphoma, status post R-CHOP therapy, last cycle November 5th, 2020, and she also has a baseline chronic cytopenia because of that. She was transferred to our nephrology clinic in May 2021 with history of recurrent AKIs over the previous 8 months due to the following risk factors: frequent fluid depletion from paracentesis, liver cirrhosis with hepatorenal syndrome, lymphoma with the R-CHOP therapy, frequent sepsis, and the history of frequent non-steroidals use. She continued her follow-up as an outpatient for a few months. She was labeled as chronic kidney disease stage 4 with baseline creatinine of 2 to 2.5 from her recurrent attacks of AKI. Eventually, she was admitted in October 2021 with fever, abdominal pain, and diarrhea, and she was diagnosed as a case of acute pancreatitis at that time. She was started on medical therapy, and unfortunately, she deteriorated and decompensated, developed AKI with low urine output, and eventually she was transferred to the ICU for acute encephalopathy. She was intubated to protect her airway, and she was started on vasopressors as well. At that time, we were consulted for her AKI. She required SLIT treatment for her acidosis and volume overload and uremia. On the next day, she improved and she was immediately extubated. She was not showing any signs of renal recovery, unfortunately, and she was eventually discharged with an outpatient follow-up, and she required dialysis twice weekly. So the challenges that we faced during this case were the following: fluid overload, hypotension during her dialysis treatments, electrolyte imbalances, namely hyponatremia, hypokalemia, metabolic acidosis, encephalopathy, recurrent anemias, and poor nutritional status. I'll go over each one of them and go over in details, and we'll show you guys how we managed each one of these. Fluid overload, her recurrent massive ascites was a big issue, and despite her requiring frequent paracentesis, that continued to be a huge issue. Other factor that contributes to that, her oliguria and her AKI, and with her chronic kidney disease stage 4, further complicated this issue, and fluid removal during her dialysis treatment became a real challenge. Intradialytic hypotension, it was mainly because of her low albumin and low oncotic pressure because of her liver disease. When she showed up at the dialysis treatments, she was having low baseline blood pressure, and ultrafiltration became a big challenge during her hemodialysis treatments. Electrolytes abnormalities, namely hyponatremia, were due to liver cirrhosis and ADH release that leads to free water retention. And also because of her poor nutritional status, her poor solute intake also played a big part in this. Her metabolic acidosis were due to the following reasons: liver cirrhosis by itself with the impaired lactate clearance, high anion gap metabolic acidosis due to her renal failure, normal anion gap metabolic acidosis with her RTA and chronic kidney disease, and the bicarbonate loss in acidic fluid, although we know that the acidic fluid is acidic in nature, but we found some case reviews and case reports that supported the bicarbonate loss during her frequent paracentesis. This is just to show how labile were her CO2 and bicarb during the pre and the post dialysis procedures. And we found a real big challenge in maintaining her normal bicarb, even during hemodialysis. Encephalopathy was big part of it due to liver cirrhosis with the high ammonia level. It was exaggerated by the frequent paracentesis and the post-dialysis hypokalemia, because we know hypokalemia induces ammoniogenesis, and that's increased the ammonia level, and that will contribute further to her encephalopathy. And it was partly due to her acidosis, high BUN, and the lack of sleep. This is also to show pre and post ammonia levels. Dialysis was very efficient in decreasing her ammonia after treatment. And then when she shows up for her next treatment, her ammonia were high enough to cause her encephalopathy. Recurrent anemias due to her baseline pancytopenia due to lymphoma and chemotherapy, liver cirrhosis by itself, erythropoietin deficiency, and also poor nutritional status. How we overcome her fluid overload, we did ultrafiltration as tolerable without making any hemodynamic instability, weekly paracentesis. She was kept on dialysis schedule, not on her paracentesis days, to minimize the risk of hypotension. And she was requiring up to 7 liters of paracentesis in each session. She was kept on diuretics on non-dialysis days, and we monitored her fluid intake. Talking about the intradialytic hypotension, her prescription were low blood flow and low dialysis flow. We adjusted her prescription according to that, and we did sodium profiling for her using high sodium at first for getting enough UF, and then to avoid hypertension, we did a low sodium bath. We used low dialysis temperature, and we supported her by midodrine during her dialysis sessions. Metabolic acidosis, we used high bicarbonate baths during dialysis, and also we supported her with oral bicarb replacement. Talking about her encephalopathy, we changed the potassium bath to 4K in order to avoid the hypokalemia-induced ammoniogenesis, and also we supported her by oral potassium replacement during her dialysis procedures. We maintained her potassium to be around 5-ish to avoid the ammoniogenesis. GI were also following this case, and they were doing the albumin infusion during paracentesis. They used laxatives, and we monitored the pre and post ammonia levels, as I showed you in the graph. Her recurrent anemias were managed by weekly darbepoetin injections, as needed blood transfusion, and also iron stores repletion. Her current condition, she's significantly improved. She's followed by Dr. Kana actually in the outpatient dialysis clinic. She's not requiring as much as high volume paracentesis. And actually her last paracentesis was back in March. And with less paracentesis, she's been avoiding hypokalemia, and eventually she's avoiding the high ammonium and the ammoniogenesis. And that improved the overall metabolic status, and she's on the active liver transplant list. The take-home messages from this case: nephrologists should assess the clinical status of each patient and tailor the dialysis prescription according to the patient's needs. And they need to be flexible in writing the prescription, because there's nothing called the one prescription that works for all patients. And also medical therapy on non-dialysis days, if the patients had residual renal function, that could also help. Thank you for listening. I'll leave the stage for my colleague to continue.
Thank you, Zaid. Good evening, everyone. This is Manoj. I will try to focus on some current and future approaches to diagnose and manage AKI in liver cirrhosis patient. So AKI in liver cirrhosis is pretty common. Almost we see around 20% of liver cirrhosis patients who are admitted in hospital, they do develop AKI. Let's begin with the type of AKI. And as you know that most of the types of AKI are pre-renal. And most of those pre-renal injuries actually volume responsive. That happens due to infection, happens due to hypovolemia from use of laxatives, GI hemorrhage, use of vasodilator, and some other toxic agent used like contrast or NSAID. Other types of pre-renal injury is volume insensitive or non-sensitive, that is hepatorenal syndrome. Intraparenchymal damage is not uncommon. The second most common category, which happens because of acute tubular necrosis, glomerulonephritis, or interstitial nephritis. Post-obstructive is very less common. Regarding hepatorenal syndrome, the current recommendation says not to classify it as HRS 1 or 2, rather to classify it like HRS AKI and non-AKI. As we all know that HRS AKI is a diagnosis of exclusion, like we need to exclude any kind of shock, any proteinuria, hematuria, obstruction, before we label the patient as HRS AKI. It is more common in inpatient, more aggressive, mortality is more high. While the HRS non-AKI mortality is less, it is like chronic or subacute form of kidney injury that happens mostly in the outpatients. Regarding the pathogenesis, let's make it simple. So pathogenesis, there are a couple of known theories and a couple of theories we need to explore. Among the known theories, the most popular one is the vasodilatation theory, which happens from this flanking vasodilation causing the sympathetic stimulation and subsequent renal vasoconstriction causing the kidney injury. While the second more common is inflammatory erythropathy happens because of the infection, some inflammatory cytokines causing the renal vasoconstriction and AKI. The third one is cardiac cirrhotic cardiomyopathy that compromises the renal perfusion and AKI. And the fourth, which is not so uncommon, is abdominal compartment syndrome. And we know that paracentesis with albumin support can significantly improve the renal perfusion, and it is a sort of helpful to address the hepatorenal syndrome. The theories which are interesting, one of them is cannabinoid 2 receptor activation. Actually, this receptor is present all over the body, and it is seen that it is overexpressed in liver cirrhosis patient. So targeting cannabinoid 2 receptor can be very interesting because it is associated with oxidative stress, fibrosis, and inflammation of the kidney. And another interesting thing to explore is chloremic tubulopathy. The chloremic tubulopathy in the kidney biopsy of the liver cirrhosis patient, it is seen that there are more deposition of bile salts, bile acids, and bilirubin. There is one receptor which is fracinoid receptor, which can be very important or very interesting target because this receptor is associated with bile acid metabolism. So fracinoid receptor has a great future for the therapeutic benefit in AKI of liver cirrhosis. Diagnostic challenges is that the margin of differentiation between the ATN or pre-renal or hepatorenal is very narrow, and the current available tests are not so specific to differentiate it among these entities. So we believe that there should be some minor criteria along with all the major criteria of AKI should be used when we diagnose hepatorenal syndrome, like patient should be oliguric, urine sodium is less than, FeNA is less than 1%, hyponatremia, and high urine osmolality can also indicate hepatorenal syndrome. Presence of muddy brown crust or waxy crust indicate ATN. So urine or serum biomarkers, especially the urine NGAL, it is very high in the patients of ATN, while it is lowish, like less than 200 in the patients of hepatorenal or pre-renal injury. So in a nutshell, when we differentiate between HRS and pre-renal, the FeNA can be useful. FeNA is low in both, but less than 0.5% in pre-renal, while it is less than 0.2% in HRS. And when we differentiated these two entities from ATN, urine NGAL can be helpful because urine NGAL is more higher than the other two in ATN. Management depends on the diagnosis. The perirenal has to be managed with volume, while HRS has to be managed with the vasoconstrictor, while ATN has its own line of management, including dialysis or liver kidney transplant. Risk factor management is important because to prevent the hepatorenal syndrome, we need to control the sepsis, we need to avoid any nephrotoxic agent. And albumin, really interesting that albumin can be used as a management, as a treatment, and as well as a preventive method of AKI in liver cirrhosis. It can prevent the post-paracentesis circulatory dysfunction, can prevent renal failure, can prevent hypovolemia, and even can prevent the hepatorenal syndrome. And that happens because of multiple action of albumin, including antioxidant function, immunomodulation, endothelial stabilization, and antithrombotic function. And this is the new hero in the market, terlipressin. We all know this V1 receptor agonist, which is causing the vasoconstriction. And by doing the vasoconstriction, it is stopping that inciting agent of hepatorenal syndrome, which is splanchnic arterial vasodilatation. And then it stops the whole scenario. Terlipressin should be, of course, very carefully used in any patient of myocardial ischemia or peripheral or coronary ischemia because of its vasoconstrictive effect. And in all the studies, it is now proven that terlipressin is effective than any other vasoconstrictor agent which we use in hepatorenal syndrome. Noradrenaline can be a suitable alternative of terlipressin, and this study, which is published in August 21, shows that it can be safely used even outside ICU as an alternative of terlipressin. The future is serelaxin, which is a recombinant relaxin 2 drug that is a vasodilator, and that will actually affect the renal vasoconstriction. So this drug can be very useful or promising in the treatment of hepatorenal syndrome in future. And in a study, it is shown that serelaxin can be more efficient even than terlipressin to manage the AKI in liver cirrhosis. And vasopressin 1A receptor is also a receptor. Some of the trials has been done. Phase 2 trial is finished, and it is shown that it also improves the renal perfusion, and it helps the renal vasoconstriction. So the take-home message is diagnosis. We can use urine biomarkers like NGAL to differentiate between the prerenal or hepatorenal and the ATN. And some of the new drugs like serelaxin or vasopressin 1, a partial agonism, can be helpful in future while we manage the AKI in liver cirrhosis. Thank you very much. And me and Zaid are ready for any easy questions you have.
Thank you. That was a wonderful presentation. Just a quick question on that use of terlipressin. I think the recommendation is to use it for the liver failure with less than grade 3. That means less than 3 organ involvement. But most of the patients that we are seeing already have a neurological involvement, coagulation, and kidney involvement. So then we cannot use it on those patients. So how would you comment on that, like using on those patients?
No, yeah, you are right. Actually, in grade 3 and higher level, it is not recommended to use the terlipressin. I don't know actually much. I didn't actually use yet the terlipressin since it is get the FDA approval. We didn't use much, but we are going to use much and see. But yes, grade 3 and higher level of liver cirrhosis, it should not be used. That is recommended. And also in the ICU patient who is on ventilator, having significant respiratory dysfunction, it cannot be used. Yeah, thank you for mentioning that point. Thank you so much. Thank you. Sure, sir. Tina.
I'm just building up a battery now. But even we have at times seen patients months and months on dialysis. You check your urine, they make only 10 drops a day. You check your urine sodium is undetectable, very low. So people with cirrhosis, chronic liver disease, when they have even severe damage to the kidney, they somehow manage to hold on sodium. So if we see FeNO is more than 1 or 2%, it helps. But if it's still low, it could be significant tubular damage, but somehow the remaining nephrons apparently are super duper absorbers. So I have had people like a patient who was 1 year on dialysis, made maybe 10 cc of urine. I just out of curiosity said, let's have a Phe sodium. It was very, very low. So although 1 year on dialysis, total kidney shutdown. So it's good if it's high, but if it's low, it still could be significant damage. Yeah.
Thank you so much for mentioning it. Yeah. I think that's it. You guys enjoy the evening. Thank you.
All right. Well, we are just going to go past that. All right. Well, good evening, everyone. And just on behalf of the St. Louis University Nephrology Division, we really want to express how delighted we are to be part of this second Renal Roundtable partnership with the National Kidney Foundation. And I specifically want to thank Kathleen, Maggie, Courtney, and the entire NKF team for their support of this important event, as well as to our colleagues from MU and WashU for this multi-institutional collaboration. And as I mentioned at the beginning, the Fellows Renal Roundtable is a program that we started last year to really celebrate the nephrology education of the region. It really means a lot to us to see everyone here celebrating with us in the room tonight and celebrating our fellows and learning and enjoying. So we have two excellent fellows presenting for us tonight, and they're here as representatives of our training program, including our first and second year co-fellows who are here supporting, as well as our diverse faculty who supported as a mentorship team. So on that background, I'm delighted to introduce the St. Louis University portion of the program. And our topic this evening is Transformative Chronic Kidney Disease Therapies, with a particular focus on SGLT2 inhibitors. And as we all know, after a long period of relatively slow innovation in the nephrology space, it's really very exciting for us as clinicians and researchers to be working in a time when there is a proliferation of new treatment options that may meaningfully impact the disease course of our patients. And so I have the honor of introducing our two fellows on behalf of the division and our faculty mentoring team. Our first fellow is Dr. Aliza Memon, and Dr. Memon completed medical school and internal medicine residency in Pakistan. And after working for a bit as an internal medicine attending, she joined Harvard University to pursue her research activities. Aliza is a co-PI on several clinical trials and has worked closely on FDA approval of some investigational drugs and devices. And she joined the SLU Nephrology Fellowship in 2021 and then became our Chief Nephrology Fellow in July of 2022. And Lisa's career goals include becoming an academic nephrologist and an independently funded investigator. Outside of work, she enjoys healthy activities, including hiking and swimming and spending time with her family and her lovely child who's with us tonight. And Elisa is very active on Twitter and with the social media handle below. Elisa is sharing the presentation with Dr. Tej Pujar. Tej attended medical school at Bangalore University. He completed residency and chief residency at the Kern Medical Center with UCLA. He also has an MBA from the Kelley School of Business. And of note, Tej is a very experienced business leader in medicine. He served impressively as the associate hospitalist director at Good Samaritan Hospital in Illinois, as well as a director of medical education. He is currently an advisory council member for the ACP, and his career goals really center on serving patients with kidney disease in the US, as well as to make dialysis more accessible and affordable in rural India. Tej lives with his beautiful family. He enjoys running and tennis and is actively involved in community activities. So please join me in welcoming Dr. Memon and Dr. Pujar.
Thank you, Dr. Lentine, for that very humble introduction. And good evening, everyone. Welcome to this delightful, beautiful evening today of the Renal Roundtable Conference. So there are exciting times with new and emerging therapies to improve disease course and outcomes for our patients. This slide shows some of the innovations Dr. Martin, our previous chair of the department, highlighted at a recent symposium honoring his perspective over the last 40 years in nephrology. As fellows, we are particularly enthusiastic to receive training in these unprecedented times and with many novel and evolving therapeutic options as listed here on the left-hand side. And the future, in fact, looks much more brighter with many emerging innovations to improve the disease course and outcomes for our patients. However, tonight, I think we're going to focus more on the SGLT2 inhibitors. And we'll reserve the rest of the innovations to be presented on the future coming RRTs. So today, the focus is going to be more on what evidence do we have with regards to the usage of SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors in transforming the care of patients with chronic kidney disease. We're also going to look at the areas of uncertainty that we have with regards to the indications, the risks, benefits, and in the special population like transplant patients, patients in older patients, and patients with very low GFR. Most importantly, at the end of this presentation and discussion, we are keenly looking forward to learn from your experience and your insight with the usage of these SGLT2 inhibitors. So here's a timeline of the landmark trials in diabetic kidney disease management. So as you can see, in the last 3 decades, in the early 1990s and the 2001, the center stage was basically the ACE and the ARB. And then you can see that pretty much there is little noise in the arena of chronic kidney disease or kidney disease for at least for the next decade or two. Until lo and behold, in 2013, we see the SGLT2 inhibitors thanks to the EMPA-REG outcome. But then the data after that, we had more and more clinical trials with the SGLT2 inhibitors, but these were focused mainly on patients with major adverse cardiovascular events such as non-fatal MI, stroke, and cardiac death. However, the secondary endpoint of these trials also revealed to us that there was significant benefit from the renal outcomes as well. So then the tide started turning more towards looking at CKD patients as a primary outcome of the renal outcomes in the CKD patients. And lo and behold, these agents proved to be game changers in the management of patients with a CKD progression. This slide is about the mechanism of action of SGLT2 inhibitors, as most of you are aware. Majority of the SGLT2 inhibitors, SGLT2 cotransporters are located in the S1 segment of the proximal convoluted tubule, which is the most proximal part of the convoluted tubule, where almost 90% of the filtered glucose is reabsorbed. And obviously, once you inhibit these SGLT2 inhibitors, you can see that it has been known that it has been seen that humans treated with these medications excrete about 50 to 60% of the filtered glucose. There are other mechanisms involved, with regards to the benefit of SGLT2 inhibitors in CKD patients. Because we block the SGLT2 co-transporters at the proximal convoluted tubule, more sodium is delivered at the distal convoluted tubule, triggers the macula densa, then stimulates the afferent arterial vasoconstriction, reduces the intraglomerular pressure, and hence reduces the albuminuria, which is also the contributing cause for an initial dip in the eGFR that we see in some of the patients with SGLT2 inhibitors. Here's a slide on several landmark clinical trials conducted over the last 7 to 10-year period. They focused on kidney outcomes and the key trials, as you can see here. The 4 major SGLT2 inhibitors that are currently available in the US, the empagliflozin, the canagliflozin, dapagliflozin, and etuligliflozin, have shown significant and consistent results in slowing the CKD progression and also lowering this cardiovascular mortality, mostly in the range of 30 to 45% risk reduction with a very acceptable safety profile. It is also notable that these trials include a large number of patients, several thousands of them, that has yielded these robust results. Initially, these trials cautiously enroll patients with as you can see, relatively higher mean eGFR. However, more recent trials have included patients with lower eGFR when the SGLT2 inhibitors were initiated, and they continue to demonstrate very promising results. Yet, there are several patient groups where the role of SGLT2 inhibitors is still unresolved. For example, transplant patients or patients with very low kidney function and patients in older adults. Therefore, we are now focusing our efforts on understanding these group of patients by examining our practice patterns. I'll now hand over the mic to Aliza Memon to dig deeper into these practice patterns. Thank you.
Thank you, Pujar, and thank you, Dr. Lentine, for such a wonderful and humble introduction. Before we go ahead and discuss further about whatever we saw in our data, I would like to see the perspectives of the audience about clinical scenarios that we usually encounter in general nephrology and transplant nephrology clinics. So let's do ahead, and the first case scenario here that a 65-year-old Caucasian with a kidney transplant recipient in 2018 with high blood pressure, BMI elevated without diabetes, although came for evaluation of advancing allograft dysfunction. Blood pressure 140s, 90s, 2+ edema, A1C 5%, GFR of 30, and UACR of 300. Last UTI was 6 months ago. Regimen: ACE inhibitors, prednisone, tacrolimus, and MMF. So what do we do next in this patient? There's a QR code here. I would request the audience to scan it, and please, let's see with the perspective, pattern of, prescription here. Pujar, you can tell me the polling, like. So do you know what the audience are mostly supporting, which Awesome. So like our audience is synced with us. So yes, it's 4, but let's see why with regard to transplant population, unfortunately, there's very limited data because of lack of inclusion of these population in major clinical trials. But we as clinicians are more generalized to some extent and starting to use this medication in transplant population, especially those who are more stable after transplant. So we looked at some of the, practice patterns. To do so, we examined a large retrospective database constructed by Dr. Lentine and her lab that links the National Transplant Registry to a large pharmaceutical warehouse claim that's from 2015 to 2021. And we examined the association of baseline clinical factors with SGLT2 inhibitor use compared to the other oral diabetic agents that were used using a multivariate logistic regression. We observed some very interesting variation in prescribing these agents, being more common in adults, more than 30, people with Asian background who had a BMI more than like a high BMI and self-pay status. By comparison, SGLT2 use was lower in females, those with Black race or any other race, publicly insured population, and those who had insurance less than college. So the question is this a real data, or there's discrepancy based on the social demographic traits like race, education, sex, and the insurance copays? So really, there's no current guidelines in the prescription of SGLT2 use in the transplant population because of the limited clinical trials that we have in this population. But we are getting more comfortable prescribing them in people who are on transplant with the stable allograft functions. Now, going ahead, moving the gears toward the CKD population, which is a very commonly encountered situation, I would once again bother you to scan this QR code and read that for you. That in the 80-year-old, that's a very old population, but not in a Black African-American background, where a person comes to your clinic with a high blood pressure, diabetes, CKD stage 3B, and blood pressure is not that bad, 110/79. No edema, last UTI 3 months ago, A1C 7.6, GFR 30, urine albumin to creatinine ratio of 300, been on insulin, maximum ACE dose, and furosemide calcium channel blockers. What would we do next as a clinician?
Majority is 56% option B, and 15% for option A, and 29% for option C.
Okay, so just a quick thing here. I mean, that's a different perspective. It's not a hard and fast rule. We just wanted to have this survey and see the mindset of the nephrologists and the prescribers here. So this patient does not have, any edema. So maybe lowering furosemide would be a better choice when you're giving SGLT2 inhibitor in somebody who's an 80-year-old. But that's interesting to see. So to do so, we would like to share our preliminary data findings on a targeted sampling that we did in our both the major hospitals at VA St. Louis and SSM Health St. Louis University Hospital. We collected the data from January 2021 to May 2022 by approval of IRB from both the institutes. We extracted the relevant data from the EMRs of the respective institutions, the key patient demographics, co-medications, relevant lab data at the time of initiation of medication were examined very thoroughly, and early GFR dips and the GFR decline at 6 months were noted. Hospital admissions, adverse events, specifically, we were trying to capture UTIs. So as you can see, 75 to 80% of the patient that was included in these convenient sample were over the age of 60. Around 2/3 of the population were reported as white, which is again very alarming, and we believe this warrants further evaluation. Common comorbidities were diabetes, hypertension, congestive heart failure, and you can see that respective reported rates are very compatible between the two institutions. We basically found 250 patients from 2021 to present at SLU, and at St. Louis VA, we found around 1,000 patients from 2018 to present, but we were able to sample 50 patients per site initially. But this is ongoing data, so we're gonna further dig out more. So in terms of SGLT2 agents of choice, EMPA and dapagliflozin were used both at St. Louis University, whereas only empagliflozin were used at the St. Louis VA Hospital. Majority of the VA patients were co-prescribed the RAS inhibitors, but the prescription rates were quite suboptimal at St. Louis University Hospital. And this again leads us to think about and dig more that why that was so. In our ongoing evaluation, the pilot cohort identified here and demonstrates that there were no UTIs and DKA at either of the institution. There was low hospitalization rate, but we saw 1 hospitalization per institute, but that was not related to the SGLT2 use, although was related to a surgical issue or CHF exacerbation. Both early and late decline in GFR were not observed, and overall, these preliminary findings are encouraging, although based on a very limited data here in this target population. So what do the trials suggest us about the use in the older population? We are very concerned about prescribing these medications in the elderly population because of the risk of hypoglycemia, volume depletion, genital infections. So let's examine the two major trials, the SOUL trial and the Datta heart failure trial. In Datta heart failure trial, around 60% of the population was more than 60 and 24% was more than 75. And Datta improved the outcome in heart failure patient with or without diabetes across the groups in all the ages, and safety profiles were comparable in all the groups. In another SOUL study from Italy, this was discontinued significantly because participants who were older, had a lower BMI, had a higher HbA1c, and a very worse outcome. To summarize, SGLT2 inhibitors are generally well tolerated and effective in older population, although caution is generally and definitely advised, especially in fragile population. What do these trials suggest us about the risk of UTI? As nephrologists or as PCP, we are very feared about this complication of prescribing SGLT2 use mainly due to glycosuria. It's a huge concern. So a recent meta-analysis from a large placebo randomized controlled trial, which include 13 major trials, including 90,000 participants, revealed the following. To date, the sampling from North America and British suggests no increased risk of clinically significant UTI with SGLT2 use. So concerns of UTI should not be a major limiting factor in considering the initiation of SGLT2 with so much potential for improving the case of a vulnerable patient group. I think we have a transplant slide that was probably missed, so I would like to share that. Yeah, I think I mentioned that the guidelines. So this is particularly relevant because we have a lot of transplant nephrologists here. I should go a little bit in detail about it. That since we were talking about the UTI, so UTIs were most frequently encountered as an adverse event in 21 out of 182 patients. This was a very limited clinical, studies that have been done. But yes, this should be one of our, concern, but not in the general population, but in transplant population. So thank you for that. And let me go to the next slide. Sorry. So the current knowledge, what we have here and what are the next steps. So as clinical nephrology fellows, our early exploration of the SGLT2 use has been very specifically targeted to this population. And we have a very limited data, around 100 patients from both the centers, but it has helped us in identifying the practice patterns across different groups in nephrologists and PCPs, endocrinologists. And in turn, we plan for the next steps in our local cohort study. We have learned that nephrologists have successfully initiated the monitoring of SGLT2 use in both diabetic and non-diabetic kidney disease. Timely laboratory investigations are very crucial, but we observed in our data that this was very often missed, and specifically if these were not prescribed by the nephrologist. So caution should be taken that. Also, in very low kidney function, both verbal and written patient education should be given, particularly to the elderly population who are fragile, but it should not be a limiting factor. Alternative medications, warning symptoms, reassurance that SGLT2 prescription coverage is available for most of the patients, often with an extra effort by us, that is the prescribers, with some pre-authorization and referral to the patient assistance program. We plan to consider the following next steps, that is to the local cohort that increase our study population, follow this for a longer time, and see the co-medication, particularly the barriers in prescribing the RAS blockers, prescribing category like nephrologists, cardiologists, endocrinologists, and potential disparities in the use of SGLT2, particularly based on insurance or pre-authorization. Future trials to address SGLT2 inhibitors in more advanced kidney disease, ESRDs, long-term benefits, safety profile, research using real-time data, and the use of artificial intelligence in monitoring SGLT2, clinical abnormalities, and lab results should be utilized. Last but not least, I would like to thank our wonderful faculty and our SLU Nephron team. I would like to mention especially Dr. Lentine, who's my mentor, and also she has helped both of us, and Dr. Philip Neri, who's our program director also, and she has been our mentor, Dr. Kana Miyata, who's our expert in SGLT2 study and has been a big help during that, Dr. Geeta Madhukari, who is our faculty at the VA hospital, but she's not here, unfortunately, with us today, but she's on Zoom. Dr. Yasser Khaliskan, thank you so much for your help and support. And our program director, Dr. Maivo, who has been very supportive to all the fellows. And particularly, we would like to recognize our PAs at SLU and VA, Kelly Fee, Ariel Chanel, and our student Kenan Meher for their support of our research. And thank you on behalf of the SLU Nephron family. And we are very welcome to any questions and discussions.
Okay, that was a yes. Oh, sorry, we'll leave that for there.
Hi, thanks for presenting. I think this is essential and you did a great job at SLU because I have not been prescribing it in transplant people because I'm scared to be the first one, but you are doing it. So it takes courage to be the first one. Question regarding none of the patients having UTI, was it because of some selection bias? Like are the patients, maybe people are being more conservative and only cherry picking those who they know may not have? Do you think that's an issue, or is it being prescribed freely across all patients?
So that's a great question. That's why we were targeting the, sampling towards people who are like more in the elderly group. So most of our population, if you see 11% population at SLU and around 6% population at the St. Louis VA are more than 8 years of age. So we were specifically targeting to see if there's any UTI because that fragile population is more prone to UTIs. But in our experience in those limited data, although I would say so 59 and 50 is not a great sampling number. So that's our second step to increase the population in our studies further to see maybe our study may be biased, but so far we did not find any UTIs or any DKAs in this population. This one. Yeah. So these are the trials. No, okay. Yeah. Right. This is not our study. We are referring this, telling that what are the risks and what should be cautious. So that's our next step to increase our cohort of the study. Yeah. Thank you. Any other questions?
I have a question. So,
and again, in our VA population, we have almost 1,000 patients that we plan to eventually take a look at. These are just first 50 that we just sampled. There is no, we not just pick and choose based off of any criteria at all.
Thank you.
excellent presentation. It's a very important topic. I like your slides, very colorful, good work. My question is, so what time frame would you suggest to start SGL2 inhibitor in transplant patients? Would you wait for few months, 1 year?
So this question, I'd say ideally be answered by some of my expertise here, the transplant nephrologist, because I personally did not have an experience of prescribing it.
Turn that around and ask you there's two things. One, in the practice patterns analysis, we're partly related to data and content. It's definitely sample for patients who are several years out from transplant. And still here also reviewing our experience. You kind of do a similar EHR extraction. It's generally people who are a couple years out, but we're interested in their experience and then we want you to comment as well.
There's no strong evidence for it. But the studies on transplant show that they started after the 3 months. So usually all the studies done after the 3 months they started. I don't know, maybe Dr. Bastan also thinking stabilization of the graft, and after that they start. That's all.
Also, it was a good question. Could there be a bias? Of course, if somebody has frequent UTIs, I'm not going to start it. So there's already some bias in selection, people who were clean, who didn't have infections, and other people who have frequent UTIs or chronic colonizers, we are not going to start that. So there is a bias inherent that, yeah.
No, I just want to say, I think we have been doing at 6 months from transplants, but we would like to make it a little bit earlier. So maybe as you mentioned, 3 months might be a good time frame.
Yeah, my question is like fellow level question.
Oh.
So we know that a patient coming with AKI, we hold usually the SC inhibitor because it decreases the renal perfusion, hyperkalemia. So SGLT2 inhibitor, because of his natriuresis or volume loss, do you recommend that it should be hold a patient if he's coming with AKI?
So of course, yeah, SGLT2 should be stopped when patient comes with AKI, and that's what we do. So,
Oh,
yeah,
okay.
yeah, we do, yes.
And I saw that couple of my colleagues, they are using SGLT2 inhibitor nowadays as a first line rather than choosing ACE inhibitor. Do you have a choice that which one should be used first line for proteinuria?
So that's something interesting. If you saw that I mentioned in the SLU data that we need to see the co-prescription or co-medication. We saw 94% of our population at the St. Louis VA had a co-prescription of RAS blockers with ACE and ARBs, but suboptimal co-prescription was seen at SLU Hospital. So we need to dig down further that why there is so discrepancy, either like there's any discrepancy there in the data. So we need to dig out further why. But ideally, yeah, that's the first choice for proteinuria or if someone is
ACE
coming.
inhibitor.
ACE inhibitor, yeah.
Thank you.
Thank you so much. Thank you, Lawrence.
Good evening, everyone. It's really great to have such activity where we have fellows from different programs come here to share their clinical and research interests. I want to thank everybody who was able to make it today and the people who are watching us over Zoom. And I hope that we'll be able to maintain this educational activity every year. Just encouraging and will inspire fellows to work harder to present their projects here. And we just need to support them and cheer for them. Today, for the WashU side, we have a more specific transplant topic. So sorry for the people who don't do a lot of transplants. We have two fellows. The first one, let me see that, that's in the left side, Dr. Swathi Velgabudi. Swathi is one of our first year fellows. Initially, actually, I asked that other transplant fellow, Raj, to present, but he was out of town and she was rounding with us. And she said, you know what, I will do it. Great. But then what happened? She's just stuck outside of the country. She was not able to renew her visa. Hopefully she will be able to come back the next few days. So she recorded her presentation and we're gonna listen to her presentation. She's very hardworking, active fellow. She is very good, very big in sports. I think she have several awards in swimming competitions. You'll not be able to see that through Zoom tonight, but she did her medical school in NRI Medical College in India, and then followed by internal medicine residency in Brooklyn Hospital Center in New York. She will be speaking about AMR outcomes and the use of some new therapy. The second presenter is our transplant nephrology fellow, Dr. Mahathi Kalipanutu. Mahathi came from Chicago. She did her medical school in India. She did her residency in Loyola in Chicago, and then nephrology fellowship, University of Chicago. She is now almost half of her career. We're excited. She already signed her for her future job. She's already got sorted this out. She's very talented. She plays violin, and she actually was one of the team player of the South Indian Krantic music. Did you bring your violin tonight? No. She's also a writer. She writes poetry and fiction. So we're excited to see the slides, how this ended up. Alrighty, so how are we gonna play that video? If you want, I think Swathi will be presentation, the first one. So you, So she would. You go first, sorry.
No, thank you. Good evening. Thank you for the opportunity. I'm really excited and also a little nervous to present before this distinguished audience. My only silver lining being that transplant is evolving and emerging, and I think we're all on a learning curve. I'm just at the very beginning, so hoping to learn from all of your expertise here. I'm gonna get started. Our topic today is neurotherapies and AMR, and I'm going to be talking about two drugs in specific, clazakizumab and carfilzomib. I will admit it took me some time to learn how to say these names. And the first one is a MAB, it's a monoclonal antibody. And carfilzomib, the closest you might have heard is bortezomib. I'll go over a little bit on both of those drugs. Let's start with the case study. So this is a young male, let's say he was 42, ESRD secondary to IgA. He got a living related transplant. Transplant has a lot of abbreviations. I'm sorry, my slide has a lot of abbreviations. So living related transplant from his mother, December of 08, 110 mismatch. This is just the HLA typing. CMV positive. I'm just gonna gloss over this slide. So he basically had an AKI. We were evaluating him for the AKI. He was lost to follow because of the pandemic. And the UPE is the proteinuria, which is also one of the first signs of rejection in a transplant kidney. Then he was found to have DSAs, which are donor-specific antibodies. And his allosure, which is a more recent test of DNA from the donor organ, was also high. The rest of the workup are infections, which are common in transplant patients. They were negative, and his ultrasound didn't show any hydronephrosis or renal artery stenosis. So he underwent a renal allograft biopsy. And the results were consistent with chronic active AMR, with peritubular capillaritis, glomerulitis, which are signs of antibody-mediated rejection, severe CG, which is chronic glomerulopathy, which usually goes along with double contouring, chronic signs of immune damage, and 50% of IFTA. So he was treated with solumedrol, rituximab, IVIG. He was discharged on a prednisone taper. We targeted a higher tacrolimus goal. However, less than 6 months after this, his creatinine was elevated again to 1.93, and he had more donor-specific antibodies. His biopsy still showed chronic active AMR with C4D, which is a marker of complement activation, which just goes with the chronic AMR diagnosis. He had IgA nephropathy and interstitial fibrosis, which was severe. And so what do we do for these patients? These are patients who have been on dialysis. They're coming for kidney transplant with the hope of getting off dialysis, having the freedom to do several things, having the freedom to lead their own lives. And suddenly they're met with more complications along the road. And what do we have to offer them? So these are two new drugs which are up and coming for the treatment of chronic active AMR. This is clazakizumab. So it is an antagonist of IL-6. Before we talk about what clazakizumab does, what IL-6 does. So IL-6 is a cytokine, which means in the world of immunology, it's a messenger. And IL-6, like all cytokines, they play several roles, but couple of important things for us, especially in the evaluation of antibody-mediated rejection. IL-6 increases the balance of T17 cells and decreases T regulatory cells, which means it revs up the immune system. It also induces B cell differentiation to produce antibodies, which simply means it's pushing the immune system to make more antibodies. And that is very relevant to us in the pathogenesis of antibody-mediated rejection. So clazakizumab, my colleague Swati will be talking about tocilizumab. Toci is an IL-6 receptor antagonist. What has led to clazakizumab is that once Toci is removed, there is a buildup of IL-6 because you're blocking the receptor. There's a buildup of IL-6. And once you stop the Toci, there's a lot of IL-6 floating around. And that thought process has led to a drug which acts directly against IL-6 itself. So clazakizumab is a potent and full antagonist of IL-6 induced signaling. And I'm going to read that, but it's okay if we don't understand it fully. As measured by phosphorylation of signal transducer and activation of transcription 3, STAT3, cellular functions, we did talk about some of these, the B cell production of immunoglobulins. It also does increase hepatocyte production of acute phase reactants. So IL-6 is secreted by macrophages in response to tissue injury. And what IL-6 does, it gives a signal to the whole body saying there's active inflammation going on. That's why we are seeing the CRP rise, which most of you are aware is an acute phase reactant and fibrinogen. So it is a competitive antagonist of IL-6 induced cell proliferation. So this in vitro pharmacologic profile supports the potential of clazakizumab to impact multiple immune and non-immune cellular processes that are central to the pathogenesis of ABMR. So there are a couple of trials with clazakizumab. This one is a phase 2 randomized control trial. It was done in Vienna and Berlin. 20 renal allograft recipients with DSA positive ABMR more than a year after transplantation with an EGFR more than 30, and they were randomized to either a clazakizumab arm or a placebo arm for 3 months, followed by clazakizumab on both arms for 9 months, with a primary endpoint of safety and tolerability, secondary endpoints of DSA levels, biopsy results, and EGFR decline. What they found was there was a reduction of DSA levels, there was a reduction of acute of antibody-mediated rejection, and a subsequent modulation of EGFR decline, which means did show improvement in antibody-mediated rejection with an increase, with a stabilization, I should say, of the EGFR. You can see here, this has a pointer. That's okay. So the red line is showing that the clazakizumab arm, and you see that the p-value in part A is significant between the arm with clazakizumab and the one with placebo. Which means there was an improvement in the clazakizumab in the treatment of ABMR. They did have some adverse effects with 5 serious infections, 2 diverticular disease complications. So they did warn, saying there's a safety signal. We need to watch out for these. But the preliminary outcomes suggest potential efficacy. The thing with clazakizumab is that once it was stopped, the DSA levels returned to baseline within 60 days. So this was a temporary effect, although it was observed, the DSAs just reverted back. This is another trial with evaluation of clazakizumab in patients with treatment-resistant chronic active AMR, rejection of kidney allografts. This was a single center phase 2 open label trial. In this one, the EGFR and the DSAs were monitored retrospective and after clazakizumab. Clazakizumab was given 25 milligrams subcutaneous monthly for 12 months, and there was a protocol biopsy at 6 months. At 12 months, stable patients entered a long-term extension. BAMF 2017 analysis. So BAMF is the criteria. It's a beautiful place in Canada. So it's the criteria which hopefully, I guess, the environment is conducive to mental brilliance. I don't know, but they conduct the BAMF every year. So that's the system for like classifying rejection. BAMF 2017 analysis of pre and post treatment biopsies showed reduction in GPTC, which we discussed were inflammation, and C4D scores, which is complement activation. So it did show improvement in chronic active AMR. The adverse effects were minimal, and they did note the graft loss in 2 patients who discontinued clazakizumab at 6 months and 12 months. So there was a trend towards stabilization of EGFR, reduction in DSA and graft inflammation. This trial didn't observe any significant safety issues. Trial Imagine is underway. This is just a sample study design from a study that's ongoing at WashU. It's placebo versus clazakizumab, 25 milligrams every month. And I think after period 2, which is 6 months, there's a long-term extension. I do see that there's a higher dose of clazakizumab also. Before we go to carfilzomib, so the study with clazakizumab is open at WashU, and we are welcome for any patients who are dealing with chronic active AMR to see if this can be an option for them. Carfilzomib, now, it has an interesting mechanism of action. Our body pretty much works with DNA, mRNA, but the main thing that actually does everything in our body are proteins. So there's an organelle in our cells called a proteasome, and it gets rid of misfolded proteins. What carfilzomib does is it stops this process of degradation of misfolded proteins. And once the cell senses that there's a lot of misfolded proteins, it actually undergoes cell cycle arrest and apoptosis. So it's fascinating how our body has so many defenses against abnormal physiology. So couple of trials with carfilzomib. There is some data on bortezomib in treatment of AMR. So carfilzomib, there are a couple of trials. These are very small trials. This one had it ended up being about 16 kidney transplant patients who got carfilzomib. They call it desensitization because carfilzomib and bortezomib are drugs which were originally developed to treat multiple myeloma. Multiple myeloma is it's a monoclonal plasma cell proliferation. Plasma cells are very, very important to us because they make antibodies. So carfilzomib is key in destroying these plasma cells. And why it is called desensitization is because the plasma cells will then stop making the antibodies. So we are basically desensitizing. So this one was about 16 patients who got carfilzomib and plasmapheresis. The IAB level is, it probably, roughly translated, it means antibody, donor-specific antibody. They just averaged the highest MFI, which is mean fluorescence index. and they calculated the IAB levels, but for the purpose of understanding, it's just donor-specific antibody levels, and it did reduce them. There was toxicity. They were looking at toxicity in neuropathy, which was observed in trials with bortezomib, but they didn't find those. They did show that carfilzomib had reduced antibodies, depleted bone marrow plasma cells. There was a low incidence of grade 3 or 4 toxicities and no peripheral neuropathy. And this is an interesting study, which was, I should have probably talked about this before the other one, because this was done in monkeys, 13 rhesus monkeys, and who had 2 skin grafts. So they basically grafted skin from whichever HLA mismatched monkey they wanted to get an organ from. Once these monkeys were sensitized, then they gave the organ to the monkeys. And they actually did belatacept, which is a T cell co-stimulation blockade, and carfilzomib, and they showed that it decreased DSA and increased graft survival. So the conclusion was that carfilzomib with belatacept reduced DSA level and significantly prolonged renal graft survival in sensitized models, but they eventually experienced AMR with rebound of DSA, with lymph node plasmablast, bone marrow plasma cells, and T helper cells, suggesting that post-transplant humoral response might need to be continuously controlled, which is similar to clazakizumab, that these therapies do work, but we are not really eliminating the memory cells here. And the body has a way of preserving the memory, and it can always get the plasma cells back. So they just come back. So that's the limitation with the studies. This is one of the studies that's ongoing at WashU. It's a multi-center open label randomized controlled clinical trial for kidney transplant treatment of active AMR and chronic active AMR, or mixed AMR and T-cell mediated rejection. And the study group investigation arm 1 is carfilzomib, belatacept, and the triple immunosuppression with steroid, tacrolimus, and mycophenolate, with maintenance with belatacept, mycophenolate, and prednisone. The conventional arm is with IVIG, steroids, tacrolimus, and mycophenolate, and TAC, mycophenolate, and prednisone arm for maintenance. So that's the end of my talk. I'm open to questions. I can try to answer them, but I think my colleague's presentation will begin now. Thank you.
Good evening, everybody. My name is Swati Valgapudi. I'm a PGY4 Nephrology Fellow at Washington University Barnes-Jewish. I apologize for not being able to do this presentation live due to some unfortunate circumstances. I'm currently recording from India, and we'll be talking about kidney transplant and antibody-mediated rejection. So in the first slide, we have outcomes of antibody-mediated rejection, which overall is not great. If you can see in the graph here, this is a graph plotted allograft survival against a time scale. And we can see that patients with no antibody-mediated rejection have a better allograft survival versus patients with antibody-mediated rejection on a time scale of 10 years. So graft survival after AMR at 1 year was 85.5%, and at the 5-year mark was about 59.3%. AMR actually adds a 2 to 6-fold increased risk of graft loss. On this slide, we have 2 other graphs which also speak about poor allograft survival in patients with antibody-mediated rejection. You can see here in graph A and B, the blue line shows patients with pure antibody-mediated rejection who have a worse prognosis compared to other patients with pure T-cell mediated rejection, normal biopsies, and even mixed rejection. So from the previous slide, it's pretty clear that the current regimen for antibody-mediated rejection, like plasmapheresis, IVIG, rituximab, steroids, is actually not doing enough. And AMR continues to have a significant risk for losing the kidney allograft. So here today, I would actually like to talk about one of the newer drugs that's being approved for the use of antibody-mediated rejection, and that is tocilizumab. Toci is a humanized monoclonal antibody against the interleukin-6 receptor, first approved for the use of rheumatoid arthritis in the United States in 2010. In the figure here, you can see that interleukin-6 basically is an important cytokine that helps with the development, maturation, and activation of the T cells, the B cells, and the plasma cells. What tocilizumab does is that it binds to the soluble and the membranous forms of the interleukin-6 receptor, and thereby it inhibits the actions of the interleukin-6 cytokine. So with tocilizumab, this is a slide showing other medications which are also some FDA approved and some still in the trial phases for blocking the activity of interleukin-6. So here we have tocilizumab and sarilumab, which is interleukin-6 receptor blocker. Here we have olokizumab, which is actually an anti-interleukin-6 neutralizing antibody. And these are one of the more newer evolving therapies, which use the GP130 as an inhibitor of the interleukin-6 and soluble interleukin-6 receptor complex, which in turn actually inhibits the transsignaling pathway and further functions of the interleukin-6. We have tofacitinib and riloxatinib, which are JAK inhibitors, which also inhibit the activation of cellular processes of immune function. Here I would actually like to review an article which shows interleukin-6 as an important cytokine and as a multifunctional cytokine. This was published by Jordan et al. In Transplantation 2017. So interleukin-6 is one of the cytokines that plays an important role in inflammatory and immune regulation, innate adaptive immunity, as well as in cell-mediated and antibody-mediated rejection. This is a picture showing the actions of IL-6 on different organ systems and cells. One of the main site of activity is on the hepatocytes, which induces acute phase reacting proteins like CRP, hepcidin, fibrinogen. In the cardiovascular system, it induces vascular endothelial growth factor, which promotes angiogenesis and also intimal proliferation, which is why actually IL-6 plays an important role in the development of coronary artery disease and mortality associated with chronic dialysis as well. Here I would like to review another article which actually shows the impact of tocilizumab in chronic antibody-mediated rejection. This was published by Xu et al. In the American Journal of Transplantation 2017. This study actually included 36 kidney transplant patients who had chronic antibody-mediated rejection with the DSAs and transplant glomerulopathy, who have all failed the standard care of treatment, which is with intravenous immunoglobulin with rituximab, with or without plasma exchange. They all received tocilizumab as monthly infusions and were monitored for DSAs and renal function and long-term outcomes. What they found in this study was that patients treated with tocilizumab actually had a graft survival of 80% and a patient survival of 91% at the 6th-year mark. And they also noted significant reductions in the donor-specific antibodies and also stabilization of the renal function, which was seen at a 2-year period. So this is a continuation of treatment outcomes of the study in patients treated with tocilizumab. On the left, we have Kaplan-Meier curves, which show, figure A shows graft survival probability of 80% in patients with chronic antibody-mediated rejection at the 6th-year mark. Again, graft survival probability in patients with transplant glomerulopathy, which is about 80% survival probability at the 6th-year mark. And we have a patient survival probability of almost 91% at the 6th-year mark in patients with chronic antibody-mediated rejection. On the right side, we have two graphs, which is basically renal function plotted over time. Figure A is in adult population and figure B is in pediatric population, and we can see that the renal function has actually remained stable throughout the treatment period. They also monitored DSAs plotted on a time scale for 2 years, and there is a significant reduction, if not stabilization, of the DSAs that we can see here. Coming to this bar chart, this is about transplant glomerulopathy in pre-TOSI and post-TOSI, and we can see here that there is actually no significant improvement in the thickness of the GBM, which is the transplant glomerulopathy score. Here I would actually like to talk about a study that was done in our hospital, which shows the outcomes of utilizing tocilizumab in acute active antibody-mediated rejection in patients who necessarily do not have chronic antibody-mediated rejection. So this is a single center observational study which was done from October 2016 to 2018, so for a period of 2 years, and a follow-up was carried out for 1 year after, up until August 2019. 7 patients were included in the study. All of them received thymoglobulin and standard immunosuppression before initiation with tocilizumab. Toci was given at 8 milligrams per kilogram dosage every month, and we actually noticed a 50% or more reduction in the DSAs and stable renal function throughout the duration of therapy. Unfortunately, one patient developed CMV esophagitis and one had a potential hypersensitivity reaction. In the extended follow-up, we had 1 patient with mixed rejection and 2 patients with T-cell mediated rejection, which we will further see in the coming slides. So here we have the baseline characteristics of all the patients involved. We can see that the age groups range between 30 to 1 patient in the 60s, includes Caucasians, African Americans, Filipinos. We have 3 males and 4 females, different causes of ESRD, and we can see that all of them have received induction and maintenance immunosuppression before the administration of TOSI. And here we have the pathology, the biopsy, the Banov scoring before the use of tocilizumab, and we can see that there is significant inflammation in all these patients, that peritubular capillaritis of 2 to 3, and we see that the chronic glomerulopathy is 0 in almost all patients except for 1, which is actually a marker of transplant glomerulopathy or chronic antibody-mediated rejection. Now this is actually a summary of all the patients involved. So we can see the main thing to focus here is the pre-TOSI and post-TOSI DSAs. In patient 1, they went down from 4,960 to 2,100. In patient 2, a significant decline from 24,000 to 5,000. Here we can see in the 6th patient, DSAs pre-TOSI was 1,849 and no DSAs were present post-TOSI. And in this patient, there was no reduction, but there was stabilization of the DSAs at 24,000. All patients have gotten at least 1 dose of tocilizumab. Reason for discontinuation, as we spoke about in the earlier slide, 1 patient had CMV esophagitis, the other patient had a potential hypersensitivity reaction. And as for the follow-up outcomes, 4 patients had stable renal function. We have 2 patients with T-cell mediated rejection and 1 patient with mixed rejection. Out of all these 7, patient number 1 and 2, so 2 patients in total, had to return back to dialysis, unfortunately. So for the conclusions of this study, I would say that tocilizumab is a good choice for patients who have already completed at least 6 to 12 months of therapy for acute active AMR. Though, however, additional studies would definitely be beneficial in determining the further benefit of therapy and appropriate duration of the treatment. The concerns of the study, I would say, is we have to monitor for rebound antibodies. There is a risk of recurrent rejection in certain cases, and we will have to follow up on the DSAs, as some have actually remained strong enough to cause positive flow cytometry. And that concludes my presentation for today. I thank you all for your valuable time. I will now pass it on to my colleague who will be speaking about other treatment options for chronic active antibody-mediated rejection. Thank you, everybody.
My name is Teuli from SLU Nephrology. I'm a guy at GN, so it's sort of alien over here. So I'm trying to prevent my GN cases to go to the ESRD or transplantation. So my question is, always I'm just admire the transplantation doctors because I'm just getting hint of the immunosuppression or management plan from the immunologic reaction from transplantation patients and then management of transplantation doctors. This is so interesting about antibody-mediated rejection is are so focused on interleukin-6, targeting interleukin-6. So I just wonder that is any background of that interleukin-6. And also furthermore, so any sort of the preclinical pharmacodynamic studies, any data you are aware, you can share with us about any specific cell types are more affecting from that the interleukin-6 production or receptor blockade, such as like, endothelial cell of glomeruli or CD4 help T cell or CD8 T cells are more specifically more high level of expression of the receptor interleukin-6 or, more benefit from that management. That is my question. Second question is, I saw that the pilot studies showing the underlying disease are mostly the GN, so IJ, lupus, and then other GN, something like that. So any difference between the underlying and GN cases or others, or diabetes or hypertensive, and any difference about responsiveness for that, and then specific treatment. And also, third question is that any like a vintage of dialysis after entered ESRD from any GN, sort of in ANCA cases, we recommend patients just remain on dialysis for a year, and then to prevent relapse of ANCA after transplantation, and then starting the process of the transplantation. So all like really, I just really wanted to get more hints from your smart transplanting doctors from that, the better quality of care. Thank you so much.
Mihathi, do you want to take care of the first three questions? And I will.
I will see you next year. I will be back with answers next year.
No. So now we have actually more patients. We have around now 30 patients that they have received tocilizumab, and it's interesting that the cases that they have rebound or more recurrent rejections are the cases who have short period of tocilizumab, like only a couple or 3 doses. But now we're trying to push for at least 1 year of tocilizumab before we stop, unless there's a side effect or viral infection. In the clazakizumab, the study actually goes for 5 years of monthly infusion of interleukin-6 antibody. So here, just like trying to show that the idea of prolonging the treatment to prevent recurrent rejection. We did not see, a small cohort. We did not see the difference between GN and non-GN. But I think interleukin-6 plays a major role in interleukin-6 antibody plays a major role in reducing inflammation. I have not seen how much data have been done in GN and how many they have any trial in GN, but it would be interesting to look at these cases. I think your second question about the length of dialysis. We don't require any time of dialysis unless like there's some crescentic GN. You want to make sure there's no symptoms, no pulmonary involvement. But we don't require the ANCA level to go down or undetected. We don't require we just make sure that are asymptomatic. There's no active ongoing inflammation before we proceed. Yeah, this one, I think it's overall, it has mainly on B cell, and actually it has interferes directly with the plasma cells, not only with the B cell, but also in plasma cells. So it will decrease the antibody production. It has also other involvement with other type of T cell. So I would say two types on T and B cell. So I think it will be good for mixed or a pure AMR. Yeah, I think Ishar has a comment.
Just did you guys either commented also on Bella, so Bella or Cafilozumab and the interleukin-6, did you effectively start using any of these agents in your protocols for antibody-mediated rejection, so or still in trials?
So we have two patients that they are only in trial. The Clazakizumab and Cafilozumab are only on trials. Ishar, do you have a
I have to say similar thing in my mind, why we are using it in the antibody-mediated rejection, but not in the T-cell mediated rejection. I look at it and I saw that it affects the B cells. We know IL-6, if there's an IL-6 in the media, it shows the CD4s converted to the Tregs. So it also causes the T regulatory cells to expand, and it suppresses the other T cells, active T cells, also the B cells. So one of them, it's making more T regulatory cells. Second, because it is making apoptosis of the B cells. I think it is affecting all sides, but we can use it in T cell mediated rejection too. That's what I'm thinking. Okay. Thank you.
Does anyone else have any questions? Well, thank you so much for attending tonight's Fellows Renal Roundtable program, and to our sponsors and presenters for their time spent speaking on these timely topics. We would like for you to stay connected with us. If tonight was your first experience with the National Kidney Foundation, please reach out to me, Kathleen.Davis@kidney.org, to learn more about the work of the National Kidney Foundation. If you have joined us in person this evening, please be sure to sign in. Our sign-in sheets were placed at the welcome table. We appreciate you checking in for our attendance records. And for those of you joining virtually, we have included a link to our evaluation survey in the chat box for you to please share your valuable feedback regarding tonight's program. All the participants from the program this evening will be receiving a thank you follow-up email that will include the feedback survey as well. We appreciate your input as we continue to plan informative, engaging Renal Roundtable programs to support the renal community. We'll now draw the winner of the raffle basket. I'm not looking. Let's see. Dr. Pujar. I have it here. Should have grabbed that. There's even a Sydney the Kidney toy in here. Something, everyone wants, right? Oh, here, I guess maybe this way. So it. Okay. But thanks again for joining us for this professional education networking event, and please have a wonderful evening. Thank you.